Surgery is one of the primary treatment options for mucinous mesothelioma if the cancer is localized to the lining of the organs and has not spread. The type of surgery will depend on where the mucinous mesothelioma originated. For peritoneal mesothelioma originating in the lining of the abdomen, the main surgery is known as cytoreductive surgery or debulking surgery. During this extensive surgery, the surgeon will attempt to remove as much of the visible tumor growth as possible from the peritoneum, lining of the abdomen, omentum, fatty tissue in the abdomen, and other organs in the abdomen and pelvis. The goal is to leave no tumor nodules larger than 2.5 mm after surgery. Sometimes portions of the spleen, stomach, intestines, or other organs need to be removed if the tumor has invaded them. To further treat any remaining microscopic tumor cells, heated chemotherapy, hyperthermic intraperitoneal chemotherapy or HIPEC, may be administered during surgery directly into the abdomen. This allows high concentrations of the chemotherapy drugs to bathe the abdomen and potentially kill any remaining tumor cells. For pleural mesothelioma originating in the lining of the lungs, chest, the main surgery is called extrapleural pneumonectomy, EPP. In this very extensive surgery, the surgeon will remove the entire affected lung, the lining of the chest wall, the hemidiaphragm on the same side as the lung removed, and portions of the pericardium around the heart. Sometimes nearby lymph nodes are also removed for analysis. Similarly to peritoneal mesothelioma surgery, heated chemotherapy may be delivered directly into the chest cavity afterwards, known as hyperthermic pleural lavage, perfusion or HPL, to further attempt to destroy any leftover tumor cells. EPP aims to completely remove all visible tumor but is also a highly risky and morbid procedure due to the extensive tissue removal and loss of lung function. It carries a high mortality rate and many complications. As a result, EPP is now rarely used and alternative surgical strategies tend to be preferred. Other surgical options that may be considered include pleurectomy, decortication, PD. In PD, the surgeon more conservatively removes only the affected part of the outer lining of the lung, visceral pleura, and chest wall lining, parietal pleura, where the tumor is located instead of removing the entire lung. Sometimes a limited amount of underlying lung tissue may also need to be taken but more lung function is preserved compared to EPP. PD aims to balance tumor resection with organ preservation. Similar to the other surgeries, heated chemotherapy to the chest cavity may follow. In some advanced cases where no surgery can safely be performed, strategies like radiotherapy before or after chemotherapy may instead be utilized. In addition to surgery, chemotherapy is a key treatment option for most patients with mucinous mesothelioma. Platinum-based doublet chemotherapy is considered the standard first-line treatment. The most common platinum-based regimen uses the drugs pemetrexed and cisplatin. Pemetrexed alone following the doublet may also be given as maintenance chemotherapy. Pemetrexed is the only chemotherapy drug that has been specifically shown to improve outcomes for pleural mesothelioma, and it is very commonly utilized either alone or with cisplatin or carboplatin. Other chemo drugs sometimes used include raltetrexte, gemcitabine, and doxorubicin. Chemotherapy aims both to directly kill tumor cells and synergize with other therapies like surgery. It is usually given systemically by intravenous infusion on an outpatient basis for a limited number of cycles depending on tolerance and response. Common side effects include fatigue, nausea, vomiting, low blood cell counts, neuropathy, and others. Radiotherapy also has an important role in treating mucinous mesothelioma. It utilizes high-energy rays or particles to damage cancer cell DNA and cause death of tumor cells. For pleural mesothelioma, radiotherapy can be used in different settings, as the primary treatment in certain early-stage cases, after surgery to destroy any remaining cancer cells, or along with chemotherapy for palliation of symptoms in advanced cancer. Intensity-modulated proton beam therapy allows pinpoint high-dose radiotherapy to be delivered to tumor areas while avoiding nearby normal tissues and may provide an advantage over conventional X-ray radiation. For peritoneal mesothelioma, radiotherapy can similarly play a palliative role for advanced disease or to supplement chemotherapy. Stereotactic body radiotherapy (SBRT) utilizes precisely targeted high doses of radiation and has shown promise for both pleural and peritoneal subtypes. Additional therapies still being researched for mucinous mesothelioma treatment include gene therapy, immunotherapy, and various targeted drug therapies. Vaccine immunotherapy tries to stimulate the immune system to better recognize and attack mesothelioma cells. Checkpoint inhibitors released the brakes on immune response against cancer. Other immunotherapies focus on activating certain killer T cells. Targeted therapy drugs aim molecules involved in cancer's growth and spread like the EGF/angiogenesis inhibitors or EGFR inhibitors. Tumor-treating fields use low-intensity alternating electric fields to disrupt cancer cell division and block growth. Many of these newer targeted and immune-based approaches show early signs of promise, but more research is still needed. A multidisciplinary treatment team approach, individualizing therapy based on factors like disease extent, organ function, performance status and patient goals, typically leads to the best outcomes. Treatment options for mucinous mesothelioma include some combination of aggressive surgery when possible, along with platinum-based chemotherapy, radiation therapy and additional locoregional therapies as indicated based on the individual case. While mucinous mesothelioma carries a somewhat better prognosis than other subtypes, long-term survival still remains challenging, demonstrating the continued need for further improvement and innovation in management approaches through additional research into newer targeted, immune, and combined modality strategies. A coordinated, multidisciplinary care plan tailored for each unique patient usually optimizes outcomes the most.